Thank you. Thank you for giving me this opportunity, and I thank all the organizers and all the participants in this webinar. I would love to share some of our experience of TMS and chronic pain. You know, chronic pain is a very difficult condition to diagnose and to treat. And I'm going to talk to you or to all of you about some of the practical aspects. So let me get started. I have a different take on chronic pain. So let me get started. The first slide is, so what is pain? It's very important to define pain, because you see, as I told, we have a different take on pain. We are clinicians, we are neurosurgeons. We are a bunch of neurosurgeons and neurologists and a psychiatrist. We all work together. So, when a pain patient comes to us with the pain, we first do a thorough evaluation as what is the cause of the pain. So, conventionally, pain is defined as an unpleasant experience due to actual or potential tissue damage. Our definition of pain is slightly different. We want to define pain as an unpleasant experience by the brain due to altered electrical activity. So you see, sometimes there may not be any damage or potential damage of tissue. Still, the patient may experience pain. So sometimes I will tell you one example where you say something nasty to a person, and then the person will say, your words caused me pain, it hurt me. Though there is no tissue damage, those words triggered some electrochemical changes in the brain, and that electrochemical changes was perceived by the person as pain. So pain, our definition is very different from the conventional definition. So we don't believe that actual tissue damage needs to be pain for a patient or for a person to experience pain. This is very important, because see, TMS is nothing but changing the electrochemical activity in the brain. And now we have defined pain as basically an unpleasant experience by the brain due to altered electrochemical activity. So by, since it's an electrochemical activity that has been altered, you can override this unpleasant experience by TMS, at least in theoretical sense, because pain is all perceived by the brain, and brain is nothing but electromechanical activity. So by altering brain function, you can alter the perception too. Conventionally, chronic pain is pain that persists for 3 months. Again, we do not believe in this definition. You see, any conventional textbook will say that the pain patient, if it continues to have pain beyond 3 months, it is chronic pain. But you see here in our practice, pain which persists for 3 months need not be chronic pain. See, I'll tell you, if a patient has a disc prolapse causing pain and he doesn't get it treated for 3 months, he'll continue to have pain. So we cannot call this as chronic pain. For us, chronic pain is pain that continues to bother the patient even after treating the underlying condition or disease. So if a patient has tonsillitis and you treat tonsillitis pain, or if a patient has a fracture and you fix the fracture and still the patient continues to have pain, then you call this as chronic pain. This is a subset of patient in whom we believe that TMS will help. So just, we have to understand what type of pain the person is in. First, if it is a somatic pain or a nociceptive pain, or which is called as a nociceptive pain, there is no role of TMS. There is no role of pain if a person has a fracture or which is non-healing. TMS, you cannot think of TMS in this patient. If the patient has a neuropathic pain, which is chronic pain with no tissue damage, but nerve generating, it is coming from nerve, it is called as a neuropathic pain, and this is the role in which TMS has a role. So chronic pain in which all underlying potentially treatable conditions have been taken care of. If they still persist to have pain, which we call as a chronic pain or a neuropathic pain, which is generating from the nerve or brain itself, we believe that TMS has some role in this group. So whenever a patient comes with pain, we have to do a thorough history. We cannot bypass this. We're all clinicians, and we have to do a thorough examination, understand what is the source of the pain, where is the pain coming from, and clinical examination. We cannot bypass all this. We have to examine the patient. We have to do, after taking a thorough history, and do some blood work. Many times these patients could be suffering from metabolic conditions, rheumatological problems, which have been overlooked by the earlier treating physician. And we even have to get some CT scans, MRIs wherever necessary to understand pain thoroughly. So you see, when we talk about role of TMS therapy in pain, we have to do a complete evaluation of pain even before we consider TMS therapy. We have to see whether there is any source of pain that is not yet treated. Only then, if there is no condition that has been left, then we can consider about TMS therapy. TMS therapy should be a last resort. It should not be a first resort. So we have to exclude. These are the exclusion criteria. The exclusion criteria is we should not jump to do earlier phase. So only when patient is exhausted, all other conditions should be considered TMS therapy. So we should not even whether the patient is having any surgical or medical problems, we should think of. And even there are certain conditions like trigeminal neuralgia which we believe do not respond. So we have tried TMS therapy in trigeminal neuralgia patients. They have not done well, so we have given up doing. So this is a surgical problem, and we treat it with surgery. So this is the limitation factors for TMS. It should not be the first option. It should be a last resort. After exhausting all medical and surgical problems, at least we need to discuss with the patient about medical management and surgical management. Still, they're not interested in any of these treatments, and if they want TMS, then we should consider TMS therapy. And then, TMS therapy is a part of neuromodulation. So, along with peripheral nerve stimulation, spinal cord stimulation, TMS therapy has also role. So it is in our armamentarium. So if a patient has a pain in one nerve distribution, I think we should go for something like a peripheral nerve stimulation instead of TMS therapy. And if the patient has a pain in the spinal cord distribution, like both lower limbs, we can consider doing spinal cord stimulation. And when a patient you think is having pain that is mostly localized to the one side of the body, and it is a cortical involvement or subcortical involvement or thalamic involvement, brain involvement, then we can consider TMS therapy. So depression and chronic pain go hand in hand. It's very difficult or rather impossible to separate these two conditions. I think chronic pain leads to depression, and depression patients usually come to us with complaints of chronic pain. So whenever a patient comes with chronic pain, we have to do all the depression scores to see whether it is actually what is troubling the patient. Is it pain or depression? And most of the times it is depression that is the underlying cause. And by treating depression, the patient does well. Where we use, so how do we use TMS therapy in our practice? We don't leave any stone unturned. We do a complete evaluation. Right from history taking, we take the history all over again, understand what is bothering the patient, do a thorough clinical examination, whether the pain is a spinal cord origin, the peripheral nerve origin, the brain origin, and we see if there is any easy treatment. and we consider TMS therapy only if there is no other possible treatment. And we have to evaluate for depression, as I mentioned earlier. Thalamic pain after stroke is a good indication. What we have used is, if the patient has thalamic pain after stroke, we have found that it is a good indication. Spinal cord injury patients, spinal cord injury patients also have used, because we believe that spasticity and neuropathic pain go hand in hand. And what we stimulate, we stimulate only the motor cortex and left DLPFC, the DLPFC. So if the patient is having one-sided paresthesias and numbness and pain, like in a thalamic pain, or after a cortical or a subcortical stroke, then we stimulate the brain that is damaged with a motor threshold of 90% and a frequency of 10, and we have used about 1200 pulses. And in all cases, we stimulate DLPFC. Wherever the pain is coming from, we stimulate DLPFC, dorsolateral posterior frontal cortex. If the patient is having depression as one of the major complaint along with the pain, we use the left and we stimulate it 1.20% of motor threshold, frequency of 10. And if we stimulate the right DLPFC, if it is anxiety is the underlying cause. So with the mistakes, we did several mistakes as we started TMS therapy for pain. The initial mistakes that we did were we had offered some TMS therapy before complete evaluation. Even before we did complete evaluation, we thought we could offer TMS therapy as a little early in the disease. That was a major mistake, and not only did these patients did not do well. Not only did these patients did not do well, and then so we decided that we have to offer it only after we exhaust all other options. And it too early in their disease. We should not offer TMS therapy in chronic pain patients very early. As a last resort, we have to try. And at the first, we used to give only 20 sessions, 30 sessions. Now we have decided that they may not help us. So we have to mentally prepare this patient that they may need extended TMS therapy. At least now what we are doing is at least 60 sessions. So if they get better earlier, that will be good. That will be good. But at least we have to tell them that more sessions is better. Our experience we have been doing for 42 months, and 30 months we initially we did not do well for pain. We could not understand, but since last 30 months we have been doing we are doing it for various indications which we did not found it very fruitful. More recent experience, as we gain more experience, we started screening our patients, and we have started very selectively offering TMS therapy in these patients, and those results have been encouraging. So I'm going to share these experiences with all of you. So I think, to conclude, chronic pain is highly prevalent, and I think TMS therapy should be used in only after we exhaust all other conventional therapies. Choosing patient is very important, and continuing therapy for long enough is also very important. Most of the studies in which we have data has been published is that they have used 5 sessions, 10 sessions, 15 sessions. I think the biggest series is for like 20 sessions. I think they are not enough. Why we have been successful in the last 12 months is that we have been offering more and more sessions for these patients. And since chronic pain is such a large, highly prevalent condition, even if you are even if you are very selective with the patient's choice, there'll be enough patients to keep us busy. So we should not compromise on the selection criteria of these patients. We have to thoroughly understand where the source of pain is coming from, treat that underlying medical and surgical condition, and only after we treat the underlying medical and surgical condition, and if the pain continues to be present, and if the pain continues to bother the patient, and if he or she continues to come to us with the complaints of pain, only then we should offer TMS therapy, not before that. And I think we should be doing more of this because we have a huge prevalence of chronic pain. And what we have learned from our experience, it's though it can be used only selectively, it's a very safe and effective in the selected group. So as I mentioned to you earlier, thalamic pain, cortical stroke, subcortical stroke, spinal cord spasticity pain, these patients have done well. Whether they have done well because we treated the diseased cortex, or the depression component got better, is still out for jury. But I think we need to do a lot more studies and use this safe and effective therapy to improve the quality of our patients. Well, I conclude and I thank all of you for your attention. If you have any questions, I'll be happy to answer.